Members, this is the appointed time. We have a quorum. So I call this meeting to order. This is the meeting of the panel on health services. Item 1, information papers issued since the last meeting. Since the last meeting, the Secretariat has issued 3 information papers. Please refer to the agenda for details. One of these information papers relates to my letter regarding proposed amendments to the Medical Registration Ordinance, and there are also 2 other information papers as referred from other panels. Item 2, items for discussion at the next meeting. Again, please refer to these papers. The next regular meeting will be held at 8:30 a.m. on the 20th of March, Friday. The administration has proposed to discuss 2 items. First, latest progress of primary healthcare development, and second, report on the new mental health initiatives and work of the Advisory Committee on Mental Health. The Welfare Panel has been invited to take part in the discussion of Item 1, that is in relation to primary health care development. As for the mental health item, we've also invited the Welfare and Education Panel members to join us. Any objection? Right. Item 3, a proposal to set up the subcommittee on matters relating to the development of Chinese medicine under the panel. The Professor Chan Wing-kwong wrote to us on the 21st of January to propose to the members the setting up of a subcommittee as mentioned above. Over to you, Professor Chan. As mentioned in my letter, Chinese medicine forms the core of the healthcare system in Hong Kong. It has been safeguarding the public health, and with the support of our country, the CMMHK as well as the GCMTI have been commissioned. The promulgation of the blueprint on the development of Chinese medicine also marks a new milestone for the development of Chinese medicine in Hong Kong. With increasing concern from society on the development of Chinese medicine, and with greater trust and confidence in Chinese medicine services in Hong Kong, I think time is ripe for us to review the development and hold in-depth discussions about the policies in this regard, so as to help promote this development and contribute to Hong Kong's role as the bridgehead for Chinese medicine to go global. Therefore, I propose the setting up of this subcommittee so that we can tap collective wisdom and contribute to the long-term development of Chinese medicine. I hope I can get members' support so that we can all provide our invaluable insights to promote long-term, high-quality development of Chinese medicine. All right, thank you, Deputy Chair Professor Chan. Members, do we agree to the setting up of this subcommittee as well as the proposed work plan and terms of reference? All right, thank you. Please note that the House Committee will consider in one go all the proposals for the setting up of subcommittees under policy panels as well as the priorities. Right, on to the 4th item, development of Chinese medicine. I see that the administration has come in. Let me welcome the team. Professor Low, Secretary for Health. He's joined by Deputy Secretary for Health, Mr. Eddie Lee. Ms. Virginia Leung, Acting Project Director, Chinese Medicine Hospital Project Office, Health Bureau, Dr. Vincent Chung, Commissioner for Chinese Medicine Development, Dr. Edmund Fong, Assistant Director of Health Chinese Medicine from the Department of Health, as well as Ms. Rowena Wong, Chief Manager, Chinese Medicine of Hospital Authority, and Professor Bian Zhao Xiang, Hospital Chief Executive of the CMHK. I will give the floor to the administration to walk us through the paper. Members, if you want to speak, please press the request to speak button. Over to you, Secretary. Chairman, members, now the first thing I should say to the panel of this term is to brief members on the latest progress of the policy initiatives relating to the development of Chinese medicine. regarding the development of Chinese medicine, we have reached a new milestone. We have a number of signature projects and policy initiatives being rolled out in phases. Last year in December, the government released the Chinese Medicine Development Blueprint. This is the first policy document published by the government specifically dedicated to CM development in Hong Kong, outlining the vision of CM development in Hong Kong, including inheriting the wisdom of CM, leveraging the motherland's development, etc. Now, the blueprint sets out goals and action plans covering 5 key domains, proposing 8 goals and 20 actions. Now, this is based on the 3 major principles. First, enhancing the healthcare services in Hong Kong, leveraging on the advantages of Chinese medicine. Second, expanding the coverage of primary health care. And also third, enhancing public education so as to promote Chinese medicine development in Hong Kong. Now, the second area is to dovetail with the national development of Chinese medicine so as to develop new quality productive forces in relation to Chinese medicine. The third point is to leverage on Hong Kong's advantage in the regulatory system and the setting of standards so that with one country, 2 systems, we can better promote our national efforts in the development of Chinese medicine so as to go global. We can be the bridgehead. At the same time, we have 2 signature institutions of Chinese medicine, that is the CMHHK and the GCMTI, gradually being commissioned starting from the 11th of December. Now, the Chinese Medicine Hospital of Hong Kong, CMHHK, is the first flagship Chinese medicine hospital in Hong Kong. There are 6 disease programs, and starting from December, we will gradually launch inpatient services. Now, the quotas have been increased for 3 times, promptly responding to the keen public demand for Chinese medicine. And there are also patients from around the world coming to Hong Kong for the services. Starting from April this year, we also have some overseas talents joining us for research and development in the CMHHK. Now, following the policy initiatives rolled out in the blueprint, we will further promote the integration of Chinese and Western medicine, and that is ICWM, and we'll also further promote collaboration in the Greater Bay Area. As for the Government Chinese Medicines Testing Institute, GCMTI, upon its commissioning, we will introduce advanced technologies and equipment as well as talents so as to enhance our capability in developing the testing methods and setting of standards. We also step up collaboration with our overseas counterparts so as to make Hong Kong an international Chinese medicine testing center. Now, it has been commissioned for 2 months. We have held over 130 seminars. It plays a pivotal role in supporting the blueprint. With the passage of the bill relating to allied health professionals covering professionals such as PTs, OTs, radiographers, and medical lab technicians, these professionals can now refer patients. They can accept patients referred by registered Chinese medical practitioners for diagnostic services. We also have the Chinese Medicine Practitioners Board working with the government in promulgating the relevant referral guidelines. There will be additional resources for the implementation of policy initiatives so as to realize the visions set out in the blueprint, that is tapping the wisdom of Chinese medicine. We will also leverage on our country's experience and resources so that members of the public in Hong Kong can enjoy quality healthcare services, and that Hong Kong can become the bridgehead for Chinese medicine to go global. As for further details in relation to the regulation of proprietary Chinese medicine and the development of Chinese medicine practitioners, please refer to the paper, and we'll be happy to take questions and comments from members. Now, let me read out the names of members who would like to speak, starting from Ms. Christine Fong, Professor Chairman Kong, Deputy Chair Mr. Chen Pui-leung, Mr. Kingsley Wong, Ms. Rebecca Chan, Mr. Ben Chan, Mr. Kitson Yang, Ms. Grace Chan, Mr. Duncan Chiu. And I will give each member 4 minutes. Questions and answer, please. Starting with Ms. Christine Fong. Thank you, Chair. Thank you, Secretary, and your team for coming to our panel. We visited a number of times the CMHHK as well as the GCMTI. I think there is great potential. But today, I am not going to talk about healthcare or its development. I'd like to talk about referrals. As the Secretary mentioned, in relation to bone problems and acupuncture services, referrals can now be made by CM practitioners to allied health professionals. Now, according to residents, the CMHHK situated in Park Seng-kok is really difficult to access. There aren't many bus routes or GMBs serving the area. As I understand, 130 guided tours have been conducted. If you want to promote the development of CM further, you need to enhance public transport services in the short to medium term. And I think this may come under the purview of the panel on transport. How about providing more charges for minibuses? And how about more frequent shuttle bus services plying the route to and from the hospital? This will further enhance the effectiveness. In the long term, I think the layout should be changed and an escalator should be provided, just like other hospitals in Hong Kong, such as Queen Mary Hospital. Because this hospital is quite costly. So can we bring people from the hospital to, say, the Lower House station by with the use of an escalator? This will be conducive to the long-term development of the CMHHK. Right, Secretary. Thank you, Chair. Thank you, Ms. Fong, for your concern about this hospital as well as the supporting facilities. Now, of course, we understand the importance of transport services. As soon as the hospital has been commissioned, we have been providing various forms of public transport support, such as feeder services from MTR station as well as GMB and bus routes. But frankly, the hospital is still in its early commissioning. The public transport services will not be provided on full scale, but with increased patronage by patients, there will be enhanced public transport support. Now, I can invite Ms. Leung to give you more details. But I just want to say that at this stage, the number of visits is not comparable to the full-scale commissioning of the CMHHK. Ms. Leung. Well, in fact, we also keep a close view on the relevant transport arrangements. We have been discussing with the Transport Department. In fact, we have increased bus routes serving not only the Lohas area but also different destinations across the territory. We have 6 GMB routes for the CMHHK with the terminus set up right at the entrance of the hospital. We also have 3 feeder bus services.
Next, Professor Chan Wen-kong, Deputy Chairman. Thank you, Chair. I would first like to praise the government's efforts for actively developing Chinese medicine in recent years. I have several questions. First, one is on the Chinese Medicine Hospital. With the commissioning of the hospital, it has been well received by the public. So I want to ask, what are the attendance figures so far? And has the administration assessed how many attendances are expected in the first year? And it is said by the Health Bureau before 65% of the service capacity of the Chinese hospitals' operations will be subsidized by the government. Will you set a cap? And if there is continuous increase in demand of the hospital services by the public, will you increase the subsidies? I also praise the government's direction in setting the Chinese material medical standards and the relevant testing methods. I think it's about how the trade can apply the relevant testing methods and standards to enhance quality and level of products. So what is the administration's plans on enhancing the capabilities of the sector in quality control and identification? And how can we promote the standards to different parts of the world so as to make Hong Kong into a Chinese medicine testing and quality assurance hub? We have many proprietary Chinese medicines registered in Hong Kong being well received by citizens and visitors alike, but there were some news reports saying how locals can't even distinguish registered and non-registered proprietary Chinese medicines and supplements. So is there any plan of the administration to really promote the brand of proprietary Chinese medicines so as to instill confidence in the regulatory system in Hong Kong? Secretary, I will ask the professor to answer the first two questions, and then I will ask Dr. Edmund Fong to answer the question on proprietary Chinese medicines. Professor Bian. Thank you, Chair. Thank you, Professor Chan. We have opened the hospital for 2 months and 2 days. So far, we thank the public support. We have indeed quite a positive feedback of the hospital services. We expect in the first year we will provide consultation and daytime services. As for service capacity, we have reviewed the situation. For private outpatient services, we have quite good feedback. That is the non-subsidized services. We have people coming from different places, Hong Kong, mainland China, UK, France, Singapore, Malaysia, to seek services. For patients, we provide general practice services, and we are trying to develop the specialist services so that on a consultation level, we can provide services in internal medicine, gynecology, pediatrics, etc. As for the subsidized and non-subsidized service ratio, what is your take on this? Right now, 65% of the services are subsidized by the government. 30% is non-subsidized. We do see an increasing demand for government-subsidized services. We are continuously assessing the demand, and we will make adjustments gradually. Let me supplement some information. The subsidy quota, the ratio being 65%, this has come up and agreed with the operator when the hospital was in preparation. We do not plan on making changes at this stage to the ratio because it's too early to say. But we will review this in due course. Yes. About the work of the testing institute, the testing methods developed will have to meet the needs of the sector. There is an advisory committee that will provide advice to develop specific testing methods, providing direction to us essentially. And after we have developed the testing methods, we have done technology transfer, and this has benefited the sector in the end. And with the permanent facilities being commissioned in October, we actually have plans to have an additional international collaboration and center, and in future we will provide more training courses to different individuals as well as have cooperation with different testing institutes in the Greater Bay Area. We also have some ads that will be on air in March that will tell people about registered proprietary Chinese medicines. We have the HKC mark. We have the reference number. That's a registration number. So as long as there's a HKC registration number, one will know it is registered proprietary Chinese medicine. Mr. Chen Pui-leung, thank you, Chair. About integrated Chinese and Western medicine services, we have seen regularization of such collaboration, and there are some pilot arrangements for some new categories. In 2024, we have care for knee osteoarthritis, and according to the paper, there will be some pilot arrangements for cancer palliative care on degenerative diseases in general, as well as for organ failures. With the commissioning of the Chinese Medicine Hospital, for these pilot arrangements, can we have more of these? Is there room for such arrangements to be expanded to other categories? I want to ask about e-health. Also, the government has been promoting the digitalization of Chinese medicine operations, but then we know that there are 1,330 CMPs who have registered on e-health. It's just 12% of the total number of CMPs. The government is adopting an incentive-based approach right now in encouraging participation in e-health by CMPs, but then we have a low uptake. Will the administration adopt other measures to increase participation of CMPs in e-health so that we will not see development of Chinese medicine lagging behind? Lastly, about promoting Chinese medicine to the rest of the world. This will be a grand project. Apart from having certifications for Chinese medicine, for drugs in particular, if we want to promote Chinese medicine as treatment to other places, perhaps we need to nurture some overseas talent. Will we try to admit students from different parts of the world for the Chinese medicine university degrees in Hong Kong so that we have overseas talents being recognized as Chinese medicine practitioners and they can practice overseas in future? Is there such plan in the long term? Secretary, thank you. For integrated Chinese Western medicine collaboration, I will ask Ms. Rowena Wong of the Hospital Authority to give an answer first. Thank you. For such services in the Hospital Authority, we have been strategic. We wanted to focus on where Chinese medicine has an edge so that citizens can be quite confident in the services. We had 3 pilot set of arrangements on stroke, pain relief, as well as cancer palliative care. We have provided standardized arrangements during our pilots. And in the past 2 or 3 years, before we only had 8 public hospitals that provided such services. Now we have 26 public hospitals as well as 70 service points providing such arrangements. And under the pilot arrangements, our strategy is to now focus on degenerative diseases as well as chronic diseases. We are trying to promote collaboration between Chinese and Western medicine to develop clinical solutions. We will extend the arrangements to other categories in future gradually. On e-health, well, e-health has been made available to CMPs. We are quite disappointed about the uptake. We want the Chinese medicine sector to actively take part in e-health. We do have some measures encouraging them to participate, and some government projects, such as healthcare vouchers, would require Chinese medicine practitioners to be on e-health before they can be eligible for such schemes. I will ask my colleague to supplement my answers. Yes. While we indeed have a not so ideal uptake, we have now extended the coverage of integrated Chinese and Western medicine, and now CMPs can read records entered in Western medicine, such as diagnostics reports, and we have since then seen 150 CMPs joining e-health. We also note that some CMPs are making use of their computer systems. They have a problem with connecting to e-health on their systems. The government has some arrangements where free software can be provided to clinics so that they can connect their systems to e-health. As the Secretary said earlier, the government has different measures. For example, for primary health care, if CMPs join the primary health care network, they have to join e-health as well. We also have different subsidy schemes, such as the healthcare voucher scheme that would require CMPs to be on e-health. Well, I believe there's content in the paper on promoting Chinese medicine into the rest of the world. Is there anything you have to add? None. Thank you. Let's move on to Mr. Kingsley Wong. Thank you. When I communicated with the sector, I believe the CMPs welcome the Chinese medicine development blueprint. I have 3 questions. On nurturing Chinese medicine practitioners' talent, I can see we only have 80 graduates each year for the 3 universities. We have a lot of people who actually applied. Can we increase the number of places for Chinese medicine degrees? I see that the graduates are of great level of proficiency because often they can pass in one take the licensing examination. Can we do more in nurturing Chinese medicine talents? I also want to see how we can better make use of Chinese medicine in district health centers. We have some tangible service being available at the Chinese medicine centers. Can we extend the arrangements to other service points? And how can we make better use of Chinese medicine specifically for clinical management? I communicated with the sector. Another feedback that I got was e-health was complex to use. Can you have a simplified version for CMPs so as to encourage uptake? Because right now the 12% uptake is not ideal. I think we have to respond to the challenges and make sure we tackle the actual problem. Secretary.
Now about university places for Chinese medicine. Indeed, I can't say that we have many places available, but local students may also opt for furthering their studies in the mainland universities and then come back to Hong Kong for practice. As for registration pathways, apart from around 80 CMPs completing local training every year, we also have over 200 graduates applying for registration who have completed training in the mainland. So that's not a small number. We can't just look at the number of places in Hong Kong in gauging the overall manpower in the Chinese medicine sector in Hong Kong. Now about the second question, preventive care, I will give the floor to Dr. Zhong. And then for e-health, I can't say that this is a really complex system. For other health professions, they have started to join the e-health system as well. Now we do have an EC Connect, which is an app. The CM sector has been asking for access to the systems of other medical professions through the e-health system. So I think connection to the e-health is a prerequisite for the CM sector. I will now give the floor to Dr. Zhong to speak on primary healthcare. Thank you. We have incorporated CM service elements in DHCs, district health centers. The CMPs who have joined the DHC network as DHC network service providers will be able to provide CM services on a subsidized basis, including acupuncture and acupressure treatment to members who are post-stroke or who suffer from OA knee or back pain. We also allow CMPs to provide health tips on disease prevention, health maintenance, and health education to the members. Apart from DHCs, the members of the public can also choose Tianjiu service at DHCs in collaboration with CMCTRs under the collaborative model. And we will follow the direction set out in the blueprint in incorporating CM in the primary healthcare system, leveraging on the advantage of CM in health management. Ms. Rebecca Chan. Thank you, Chair. I think the public are concerned about the CM services as well as when they will become available to the public. Now, according to the Chinese Medicine Development Blueprint, a timetable is proposed for the list of diseases and services of CM that should be prioritized. Now we have the Commissioner for Chinese Medicine Development. We also have the CMHHK as well as PMC in Hong Kong. Can you expedite the progress? Because there is keen demand from the public. The second is about integrated Chinese Western medicine. We want further integration and collaboration so that the public can benefit from it. Is there any measure to promote CM among Western medicine practitioners? In the next item, will we put in place a mandatory requirement for general physicians to learn about Chinese medicine theories? Now, the third point is about legislative amendments regarding CMs. The registration system was put in place in 2003. The sector, however, ran into difficulties in testing for PCMs. The government then extended the transitional arrangements until as long as 20 years, that's 2025. Now, in 2018, the sector was consulted about the legislative amendments and the definition of PCMs. It's been years. Will the government consult the sector again to see if they have difficulty in complying with the proposed legislation? And will you consider their views in the formulation of the policy? About diseases which Chinese medicine would have an advantage in their treatment, I will invite the commissioner to speak on that, because they already have 12 special disease programs under 6 disciplines. And there will be more such programs set up, and guidelines will be clinical guidelines will be provided by the CMHHK as well. Dr. Zhong. Thank you, Ms. Chan, for the question. Now, the National Administration of Chinese Medicine last year updated the list of diseases where Chinese medicine would have advantage in providing treatment. We'll have regard to their lists so that, be it primary, secondary, or tertiary healthcare in Hong Kong, we will refer to the list, and we'll also focus on diseases that CM sector in Hong Kong has an advantage in providing treatment. Now, as the Secretary mentioned, this is the first year of the commissioning of CMHHK, and they've started with 12 special disease programs in the first year. There will be more to be rolled out in phases. That's over 20 programs in total. We need to gauge experience in terms of primary health care as well as GOPC and inpatient services, and then go further. We'll also make reference to experience in other places so that we have a better foundation in taking things further. Now, we also have our country's support in terms of their experience and resources, and as pointed out in the blueprint, we will definitely move towards expanding the coverage of CM in Hong Kong. Now, Professor Bian can tell us more about the disciplines. In terms of development of the CMHHK, we have prepared 23 special disease programs in total. And this year, we have commissioned, since the commissioning of the CMHHK, we have completed the clinical guidelines for 4 special diseases. And in the process, we'll continue to enhance the clinical guidelines so as to achieve better efficacy and safety. In the future, we'll strive to promote these programs so that the CM sector can tap the Greater Bay Area market as well as other countries in exporting our service model. Now, we have started 12 special disease programs in the first year, and we will continue to expand the coverage to 23. Right, Secretary, anything to say on making mandatory for Western doctors to learn about Chinese medicine? Well, this is about continuous training and education. In fact, for medical students, to a certain degree, they learn about Chinese medicine, and after they've graduated, for practicing doctors, they need to undergo continuous professional development. And this falls under the purview of professional autonomy. About legislative amendments, this year, the Hong Kong Center for Medical Products Regulation will be established. So relevant pieces of legislation will be amended. They relate to medicine as well as medical equipment. As for Chinese medicine, be it equipment or PCMs, they would come under the regulation of the same center as well as the GCMTI. So at this point, I'd like to invite Dr. Edmund Fong to explain the regulation of the CM sector. Thank you. As mentioned by Ms. Chan, in 2018-2019, the administration proposed legislative amendments to the CM Ordinance, Chinese Medicine Ordinance. As set out in the blueprint, the government should kickstart the legislative amendments again. It's been 6 years since 2018-19. There have been major changes in the market environment as well as the types of products available. So since the promulgation of the blueprint, the sector representatives have got in touch with us. They would like to start a dialogue with us. And we will definitely talk to the sector to learn more about the current market situation before deciding on the details of legislative amendments as well as implementation details for smooth compliance. Next, Mr. Ben Chan. Thank you, Chair. Now, there have been problems with Chinese medicines in recent years, as pointed out in the blueprint. There have been fake, bogus products found. The problem was first revealed 10 years ago. That was also the background of the proposed legislative amendments. Now, 10 years on, the problem has now become a very serious one. Now, for very famous Chinese drugs, they don't come under the registration regime, but rather they are registered as food. In fact, if they are sold to visitors or tourists, they will tarnish Hong Kong's image. This is a major loophole, and 10 years on, the problem has remained. The government will start consultation again. I'd like the government to explain to me the proposed legislative amendments and how you are going to eradicate bogus drugs in the market so that PCMs can be properly registered for the benefit of the public. At least tell us where you're heading, because if you don't have any concrete proposals, what can you do if you consult even if you consult the sector? The second point is that I am happy to learn that the CHIK has been commissioned. I hope that this hospital can be operated on a sustainable basis. I remember back then I put this question to the administration. This is about the sustainable operation of the CHIK. The government back then responded that subsidies will be provided. So when I asked for the nitty-gritty, the government explained that subsidies will be dispersed on the basis of the number of patients. So if we continue with this subsidy model, how do we make sure that the operation of the CHIK can be sustained? Is it really a sustainable option? So can you tell us more about the operation of the hotels, of the hospital, so that we know that it's viable? Secretary. Now, to answer Mr. Chan's question, I'd like to refer to this concept in Chinese medicine, and that is Chinese medicine and food actually serve the same purpose. food can be medicinal in nature in preventing or treating diseases. Right, I get that, Secretary. I'm not saying that Chinese medicine cannot be consumed as food. I'm saying that some some products are being treated as life-saving drug when they're actually food products. I want to explain that under the regulatory framework, this is how it goes. If this product contains food substance, then it can be exempted from the registration as a Chinese medicine. Now, in fact, if it's for medicinal use, it should be regulated. So this is a gap in the legislation, but we also need to respect this concept of medicinal use of food, such as certain herbal plants and food items. It also carries medicinal purpose. It's important to consult the sector. As for the subsidy model of the CMHK, under this subsidy model, the government procures services, and that when services are provided to the public, they would come with an affordable fee. And we also have another non-subsidy model that's for CMPs to take private patients. If you're interested, I can give you more information.
Chair, excuse me, let me clarify something if you will allow it. Sure. My question is actually very clear. I ask for the sector to be consulted, and there should be direction what legislative amendments are needed to prevent the life-saving drugs will be registered only in food. I believe the Secretary said they do note there is a gap in regulation. After consulting the sector, they will have some legislative amendments. I will let the Deputy Secretary answer this question because at one point it was said that only at 2030 we'll have new amendments. The Department of Health will be taking forward such work, looking at the definitions and what descriptions there have to be. The Department of Health will provide more details in due course. If Chair will allow it, I will also talk about how it is only when 2030 that this will happen. We asked Ms. Chen Hoi-yan to rest assured we won't wait until 2030. While it is a medium to long-term measure in the Chinese medicine development blueprint, we do want to, in future, we have a different model where CMPs will be able to make use of modern technologies such as X-rays for diagnostics, and they can also make referrals to allied health professionals. Thank you. Mr. Yang Wen-kit, thank you, Chair. I agree with the directions in the Chinese medicine development blueprint. They have made clear what the development blueprint is for the future of Chinese medicine. It is about instilling confidence in the people so that more people will use Chinese medicine services. On a primary healthcare level, you have services provided in DHCs, but then for some large areas, you only have one DHC. Will you have funding or some sort of ways for social welfare organizations in future to provide Chinese medicine services? Right now, the organizations already provide free consultation days. So if you can provide more resources to organizations, we can perhaps enhance community participation. And I think this is a general direction we should take. I also want to talk about e-health. The Secretary talked about the uptake being quite low. I wonder what the problem is. I believe younger CMPs, it would be easy for them to make use of computers uploading information and whatnot, but then for the older CMPs, it may be hard to get them to join because they may need to hire an additional individual to do the relevant operations, and it is hard for them to use the system themselves. But I wonder if we can say just make deductions with the use of healthcare vouchers so as to boost uptake. We should put in a transition period to facilitate adjustment, though. Thank you, Secretary. For DHCs, we don't only have DHCs. We have DHC expresses. We also have some satellite service points. So I believe the figure is more like the range of 5 to 8 in each area. Citizens, especially elderly persons, can make use of healthcare vouchers, and they can have that use in different service points. Things are quite convenient right now. And we have seen in the past year, healthcare vouchers are widely used for Chinese medicine services. It is the second highest in category. I heard what the members said about free consultation services. We now have the health care vouchers. We also have the Chinese Medicine Development Fund that can provide funding support for certain projects. For e-health, we understand that the older or more experienced CMPs, it's not just CMPs really, with Western medicine practitioners, it is hard for them to take up new technology and digitalization. The government will provide support to them for them to learn such technology. Many people may think CMPs are old. This is a stereotype. We have many young CMPs. We have every year both those graduating in Hong Kong or those coming back from the mainland, 300 odd CMPs. So it's not that CMPs necessarily don't know how to use technology. There are a lot of young CMPs, and we also, for customers, patients, there are a lot of youngsters seeking Chinese medicine services. I would like to clarify something, Chair. I didn't say CMPs are necessarily old. I just said older CMPs may have trouble making use of technology. I also want to see if there will be a transition period, as I asked earlier. And if we have to have all CMPs make use of e-health, how will we make deductions in healthcare vouchers? Because if you compel them in using e-health, and if people can't distinguish between different CMPs, there may be an issue. And for Kowloon City, we have 8 service points, but the population is 430,000. That is far from enough. So I want to ask specifically how we can expand the network. Basically, I've raised views for the Bureau's consideration. I believe the Secretary said earlier they would provide support to older practitioners, Chinese medicine or Western medicine practitioners. As for development of DHCs, we will discuss this next month when we talk about primary healthcare services. I will now ask Ms. Grace Chan to speak. afterwards, I will draw the line. Thank you, Chair. My question takes the perspective of patient organizations. So we have some medication that is subsidized with Western medicine prescribed medication. I believe for Chinese medicine, we will also have a similar register where we can see which drugs are subsidized, which are not. But then sometimes when patient organizations communicate with the hospital authority, there's no clear information. How can we make sure there is awareness of such information? With the development of Chinese medicine, we have CMPs referring patients to clinical diagnostic services or allied health services. In the long term, what is the blueprint for cross-referrals between Chinese and Western medicine? If we can have cross-referral between Chinese and Western medicine, patients do not have to go to a Western medical practitioner before they can be referred. Secretary, with Western medicine, a drug formulary is a mature concept, but then for Chinese herbs, it is not yet a mature concept. Especially for decoction pieces, there is essentially a recipe. It is not just a single ingredient like many Western drugs are. I think if we need to establish a drug formulary, it would take consultation of the sector to see if this is even feasible. I will perhaps ask Dr. Vincent Chung to provide more information. Thank you. With Chinese medicine prescriptions, when decoction pieces are prescribed, it would be different for each patient what the ingredients are and what portions there are. And sometimes we would make use of existing prescriptions and then add or minus some drugs. So we do not necessarily need a drug formulary. With the 18 Chinese medicine centers for subsidized services, the charges for Chinese herbs are standardized. I believe with our existing arrangements, it already provides good services to the public for prescription of Chinese herbs. As for those who have particular needs, such as CSSA recipients, even without the drug formulary, they will still be able to get subsidies. So please rest assured. What about the question on cross-medicine referral services? Right. There is professional judgment. Say if a CMP sees a patient, if they think the patient needs Western medicine services, I believe they would already be making such a recommendation. Another component is awareness. We emphasize time and time again that in the Hong Kong healthcare system, Western medical practitioners will have to be aware of what Chinese medicine can do, and that applies for Chinese medical practitioners as well. For specific referral arrangements, I wouldn't say we have a blueprint. We rely on professional judgment of medical practitioners. In the hospital authority, there is integrated Chinese and Western medicine so that there is a model for provide team-based services to provide the help needed by patients. I'll let my colleague provide more information, Ms. Marina Wong. Thank you. In the hospital authority, we have a team of integrated Chinese and Western medicine. Say for knee osteoarthritis, we have CMPs, we have medical practitioners in Western medicine, physiotherapists, and other allied health professionals. CMPs will be providing a structure, and when necessary, professional services can be referred.
Next, Mr. Duncan Chiu. Thank you. I declare that I'm chair of the IT Committee of the Hospital Authority. I welcome the initiatives provided in the Chinese Medicine Development Blueprint, including the provision of clinical services with excellence and leveraging technology to promote the development of Chinese medicine. Now, we just talked about ICMW as well as sharing of data. I'd like to ask about e-health. As in paragraph 26, the uptake rate among CM practitioners was just 12%. 1,330 CMPs sign up for e-health. Now, do you have the breakdown of the 1,330 CMPs? How many of them are in the private sector? Do you have further breakdown? Can you explain this hiccup? Because it has nothing to do with age. It's just a matter of time and how much time it takes to get used to the system. I think the resistance may come from the private sector. So will you hold focus groups so as to invite CMPs, regardless of the age, to come together and see what else can be done to improve the uptake without imposing a heavier burden on them? Because with such a low uptake rate, it won't help much in improving clinical R&D capabilities. We need more data. The e-health, it's a one-stop platform. It's for the CMPs to decide whether there is a need to access patients' information from the database with data coming from other healthcare professions. We hope that we can incentivize them to join e-health. Like Mr. Duncan Chiu said, it would be very crucial to enhancing the service quality. Now, another major incentive is that for Western doctors, you need to join e-health in order to accept patients using vouchers. So it's a matter of chicken and egg. We can also ride on the voucher scheme as an incentive for CMPs to join e-health. Now let me invite my colleague to say more on the relevant measures. Mr. Lee. Yes, for e-health, there are two measures. First, we invite service providers to give out free software for CMPs to connect to the e-health system. Second, in the CM Development Fund, we also subsidize CMPs in procuring computers to upgrade their IT system for connection with e-health. The third point is about the figures. As mentioned by the Secretary, about 1,330 CMPs have signed up for e-health, whereas for the voucher scheme, 4,700 CMPs have signed up. So one of our goals is to encourage those under the voucher scheme to join e-health as well. I don't think computer is really a novel thing for CMPs. Many of them are using the computer systems for the voucher scheme. It's just a matter of incentivizing them to join eHealth. Right, my point is to set up focus groups and invite CMPs to give you feedback so as to improve the arrangement. Mr. Peter Shiu, the last one to speak for this round. In relation to the Chinese Medicine Development Blueprint, is a comprehensive policy document. So I thank the CMP board for the blueprint. For action 4.1, it is said that we should review the quality and standards of Chinese medicines. In fact, in recent week, we've heard about the media reports on bogus Chinese medicine. Now, some PCMs available in the market are actually not PCMs. They are not registered. They circumvent the regulation by including some additional ingredients. The packaging is similar to the traditional PCM product. So this is unfair to the sector, and this is quite confusing for the public. Now the government will review and enhance the CM quality and standard. In fact, we've been discussing this issue in this council for many years. It's just as simple as the 7+1 nutritional labeling. So I think more should be done to clarify the situation for the public. Next, about GMP, and that's in this chart 3.3. What if a small operator has the formula but not the means to scale up their production? Will subsidies be provided so that they can go through the GMP process and further promote their products to overseas markets? On registration, perhaps I'll see if the Secretary would like to supplement. I will invite Dr. Fong from the Department of Health to take that question on GMP. Right. For PCMs, one of the requirements is for the product to comprise only Chinese medicine. So if there is an additional ingredient that is not Chinese medicine, then according to the law, there is no need to have this product registered. However, in terms of trademark and naming of this product, if it's the ingredient may not be purely PCM, but then this name may be very similar to a PCM product, and this is a confusion. In fact, according to the law, if there is a claim that this product has any medicinal or therapeutic use, then it will have to be registered. That's the case for Western medicine. Now, in fact, the Department of Justice the Department of Health enforced the law in the past in relation to these products. In fact, in 2018-19, in the consultation exercise, we proposed two options. First, we proposed amending this definition of PCM. Instead of a PCM that comprises only CM ingredients, we include a list in the schedule, and that if these ingredients are also included, then this product will have to be registered. The second option is in terms of the names of products. If the names that really sound like a traditional PCM are used, then these products should be registered as PCMs as well. The objective is to avoid causing confusion between the PCMs as well as this PCM-like products. On GMP, anything to add, Secretary? GMP is all about quality assurance. GMP is put in place to safeguard public health. Many places in the world, including our country, have put in place the relevant GMP laws. Now, small operators may have problems complying with the GMP requirements, but for the sake of quality assurance, they must meet the GMP requirements if they want the products to go global. We understand the plight. We have, say, the CM Development Fund to help these small players so that they can meet the GMP requirements. We also need to have regard to the quality of products as well as the development of the industry as a whole. So we must make sure that GMP requirements are met, or there will be a major hazard. All right, thank you, Secretary. We now move on to the next item, and that is legislative amendment proposals and related measures for reforming the Medical Council of Hong Kong. Let's invite the administration to come in. We are joined by Professor LEUNG, Secretary for Health, Deputy Secretary for Health, Ms. Elaine Mack, Dr. Ronald Lam, Director of Health, Ms. Janice Chung, Head Boards and Councils, Department of Health, and Mr. Patrick Wong, Deputy Head Boards and Councils, Special Duties, Department of Health. Welcome to the meeting. Members, if you want to speak, please press the Request to Speak button. This is a legislative proposal, so all members are invited to join our discussion. I will now give the floor to the Secretary to walk us through the paper. Chairman, members. The Medical Council of Hong Kong is a statutory body established under the Medical Registration Ordinance. It covers different functions, including licensing examination, registration of general physicians, specialists, as well as the special and limited registration of locally trained as well as non-locally trained doctors. It draws up professional codes and guidelines with a view to maintaining professional standards among doctors. There are also powers given under the law to handle complaints and conducts disciplinary inquiries into them involving professional misconduct. The Medical Council plays a crucial role in ensuring professional conduct of medical practitioners. It's a matter of trust. The medical profession in Hong Kong has all along upheld the principle of principal autonomy with a trust for doctors among the public. In relation to the decision of the inquiry panel that has sparked major public concerns, our Bureau demanded a report to be submitted in December last year with review on the complaint and disciplinary inquiry mechanism with recommendations for improvement. The Ombudsman also published a report in May this year in relation to the Department of Health's support for the complaint handling procedure of the Secretariat of the Medical Council of Hong Kong. This is a direct investigation report. In order to ensure that professional standards are met and public health is safeguarded, as well as bolstering the trust between patients and doctors, we have decided to amend the Medical Registration Ordinance and reform the Medical Council. and there will also be enhanced administrative support by the Secretariat. We started consultation with different professional bodies and patient groups and stakeholders in January this year. Now, we propose to amend the legislation following two directions. Without compromising professional autonomy, we want the Medical Council to be able to fulfill its functions more effectively. The first one is to reform the composition of the MCHK and enhance complaints handling process. Regarding the composition, at present, MCHK has 32 members comprising 24 medical practitioner members, 75%, and 8 lay members, 25%. Now, when it comes to handling complaints, apart from members of the MCHK, there are also 84 other members, lay members, comprising representatives from the Bar Association, Law Society, patient groups, etc. There are 84 independent assessors, 48 of them being doctors, 36 of them being other professionals such as accountants, etc. These independent assessors will join the inquiry panels on a rostering basis to handle complaints. Now, we'd like to enhance the composition along these directions, increasing lay participation in healthcare professional regulatory body, so that there will be a more diverse representation of different sectors, including non-official medical practitioners directly appointed by the government. Second, we will also consider enhancing other medical practitioner members. The third is to include primary healthcare representatives to reflect the development. The fourth is to have additional members from the third medical school. As for enhancing the complaint procedures, starting from the end of 2024, we have put in place enhanced administrative procedures such as improving the arrangements for initial screening, as well as information system for legal representatives, expert witnesses, as well as enhanced case monitoring by the Secretariat. And we will further enhance the complaint handling procedures. For example, we will require that target processing time frames for different parts of the mechanism be set. We will also enhance the overall transparency and predictability of the progress of case management. Third, we will also enhance the independence of inquiry panels and enhance the assessors in the participation in the inquiry panels. We will also adjust the composition so that it aligns with the inquiry panels. Now, at the moment, PIC is the body for screening out complaints that are frivolous and groundless. We will enhance the procedures to enhance credibility.
We also have in plans to include in the laws the Medical Council's responsibility to supervise the Secretariat's work. We also will allow complainants or the doctors being complained of to lodge appeals to the Medical Council or to the court about decisions made by inquiry panels. For medical practitioners who are convicted, we will ask for the inquiry panels to just adopt the judgment of the court. If medical practitioners are given a prison sentence for a certain term, they will be removed from the registered, and whether they can re-register will depend on the nature and seriousness of the offense. Apart from the aforesaid amendments proposed, we will also seize this opportunity to amend legislation to enhance doctors' professional standards by asking doctors to undertake continuing medical education. For nurses, dentists, and allied health professionals, we have implemented similar requirement for continuous professional development. But then right now for medical practitioners, we only ask specialists to undertake continuing medical education. To maintain the professional competence, we will extend the relevant requirement to non-specialist doctors. That is, it will cover all registered medical practitioners, and we will make it into a prerequisite for renewal of practicing certificates. We also have for special registration pathway for the registration of medical practitioners. We have many restrictions for non-Hong Kong permanent residents. We have seen, as a result, the special registration pathway is not particularly attractive to non-locally trained doctors. So we want to expand the pathway to make it easier for non-locally trained doctors to take the special registration pathway, but we will continue to prioritize employment of local graduates. Apart from amending legislation, the government will enhance support provided by the Department of Health to the Secretariat of the Medical Council in administrative arrangements, and we will only with the recommendations of the Medical Council support the work of the Medical Council. We will not be replacing or intervening in the Medical Council's exercising of functions. We have the following measures. We will enhance the Director of Health's role as an official member, ex-official member of the Medical Council. We will also support the Medical Council in having someone with professional background and senior management experience to be the head of the Secretariat of the Medical Council to enhance governance. We will also have a dedicated team to investigate complaints. We will also increase the deployment of legal support personnel and administrative personnel. The government has also invited experts so that we can have systematic organization of experts from different disciplines to provide advice as expert witnesses. We will also provide training and support to members of the council as well as assessors so that they know what functions they have to exercise. We believe with the reform measures, it can maintain professional autonomy and procedural fairness, and it will also enhance the efficiency of complaint handling, instilling confidence in the people. We see the need to continue to develop medical profession and ensure service quality, and we will submit the legislative amendments to the council for scrutiny this year. Thank you, Secretary, for your presentation. We have at the moment 10 members who have pressed the request to speak button. Ms. Chen Ho-yen, Reverend Peter Kun, Ms. Professor Chen Wing-Kwan, Mr. Chen Pui-lun, Mr. Chung Ho-fung, Mr. Adrian Ho, Ms. Grace Chen, Mr. Chen Ho-fung, Mr. Nick Chen, and myself, Ms. Chen Ho-yen. I will assign a 4-minute time limit. Questions and answers included. Ms. Chen Ho-yen. Thank you, Chair. Well, we have been calling for medical council reforms for many years, not just after the particular case. I think for patient organizations, patients, family members, and even doctors, there is a need for the comprehensive reforms to be made. And I hope that in the interim, the administration can really hear feedback from different sectors. The Ombudsman said there are many cases. 70% of the cases are not handled after 5 years. We have 11 that are not dealt with within even after 10 to 15 years. So can you also hear from the complainants who have been in limbo for so long what reforms are needed? Have you asked for their views? The Medical Council will continue to receive complaints. They will commence the inquiries. They will make a decision. All of the functions are concentrated within the Council. The public's impression is that this will not lead to fairness. I believe it is now the opportunity for you to split some powers and take them out from the council so that there is fair hearing. In the Medical Council, will you consider amending the membership to have arbitration or decision functions in inquiries to be done by a third party? I think some powers should be delegated. We have seen the paper talk about different measures about reforms of the Medical Council. I also know there are some proposals on continuing medical education requirement for non-specialist doctors. Can we take a more focused approach? Can we focus only on reforms of Medical Council so that we will not have other issues detract from what we should focus on? Secretary. Thank you, Ms. Chan, for your questions. It is as you said, we want to have comprehensive reforms. We need to identify what caused the delay. There's no single reason, really, and we need to therefore take a targeted approach. We thank the Ombudsman for giving certain examples in their report, especially those cases with a significant delay. And I would like to say this, in 2024, the Medical Council already took the initiative to proactively find out what cases there are that has a delay. So many of the cases, according to the Ombudsman's report as well, were identified by the Secretariat. And we have found the reason is, for example, we have to wait for a judgment from the coroner's court, and then the process would have to start over. They would have to go back to the preliminary investigation committee even when they have already reached the stage of inquiry panel. And according to the Ombudsman report, there were on 2 occasions where this happened, that because of a judicial process, the process in the Medical Council had to start over, so that after 10 years, they are still at the preliminary investigation committee stage. One was a judgment was released by the coroner's court. The other was due to there was change in the expert witness opinion, that there was another expert witness. So we have identified reasons through these cases that were identified on the efforts of the Secretariat. We now know the reason. We do understand the family's concern. I think we're at a stage where we have to explain what happened and make sure we resolve these cases and make sure something like this does not happen again. The members said there may be an impression that every function is concentrated within the Medical Council, but then let me remind you that there are independent assessors within the Medical Council. It's not just on the Medical Council members. Many independent assessors, I won't talk about where they're from because I talked about that earlier, but we have participation from different bodies. And the independent assessors are, as the name suggests, independent, and their participation sometimes is not even known to members of the medical council. Well, we do note with this process, there is no proper supervision from the medical council, and that has caused some issues. As for what you said about we should not include other amendments that are not related to the reforming of the Medical Council of Hong Kong in this exercise, we would argue otherwise, because these are some complex amendments, and these are major amendments, and we want to implement them as soon as possible. Thank you.
Reverend Peter Kun. Thank you, Chair. In Hong Kong, the healthcare professions uphold the principle of professional autonomy. That's the case for doctors and the medical council. But the trend has now changed, especially in the UK or other Commonwealth countries. The emphasis is no longer on professional autonomy. The government will carry a heavy responsibility. So people tend to blame the government. So I think this is a right opportunity for us to make a change. Now, as I understand, chairman of the Medical Council is returned by election among members. Will the government consider appointing the chairman directly, be it by the government or by the chief executive, and that the deputy chair should be taken up by a layman or a non-doctor in order to enhance credibility? The other point is about sentencing. Can you publish the sentencing guidelines and explain to the public? Because it's quite misleading. There is this restoration hearing. Well, it takes very often the license will only be suspended for 2 or 3 months. It's not a very good perception among the public. So I think you should, put in place a longer suspension period, say 2 years, and if there is nothing untoward, the license can be restored at the lapse of this period. Otherwise, I think it's quite shocking to learn that it will be suspended for just 2 or 3 months. Secretary, thank you, Reverend, for your reminder. Of course, the government is responsible, but I want to emphasize that in Hong Kong, the medical profession upholds the principle of professional autonomy and discipline. With rights comes responsibilities. It's for the profession to exercise autonomy as well as discipline. They are responsible for self-regulation. When it comes to the development of healthcare, we have some new trends such as peer review, and it's for the respective professions to review the practices and conduct self-regulation through peer review. In fact, in each hospital, in each department, they also have peer review. Say if serious complications or even death arise from a surgery, then internally there is a very stringent peer review process for a member of the profession to determine the case. Now, at the level of the medical council, you need to go through the legal procedures. In fact, in an inquiry panel, there are actually more lawyers than doctors. There are 3 medical practitioner members as well as 4 lawyers. This is because each complainant is entitled to appoint a legal representative, and together with a legal advisor and a legal officer, altogether there are at least 4 members to ensure procedural fairness. Now, in this particular case, the chair of the inquiry panel happened to be the chair of the Medical Council. As for the PIC and the inquiry panel, as I emphasized just now, they are not necessarily composed of members of the Medical Council, but rather by the 84 assessors. And these 84 assessors are not the same as the 32 members of the Medical Council. So this decision is to be independently made, separate from the decision of the Medical Council. The announcement of the decision, however, is to be made by the Medical Council. Now, as for the so-called suspension of license, the Medical Council's decision provides a time frame. At the lapse of this suspension period, the license will not be restored automatically. It will be up to the doctor in question to apply for restoration. And it's not just as short as 2 or 3 months. It may take 2 or 3 years before the license is properly restored. So there is a misunderstanding here. Now, I hope members of the public will understand that even if you order the license to be suspended for just 1 day, it's still an indefinite sentence. It takes time for the doctor to apply for the license to be restored. So I want to explain to the public that when it comes to license suspension as a form of sentence, you should not just look at the suspension period. Of course, for any wrongdoing, the doctor in question deserves punishment, but more importantly, the sentencing guidelines should serve as a starting point. Apart from punishing the doctor in question, we want to protect the public. That is, we consider what the substantive question and whether by restoring the license, the doctor may commit the same offense again. We need to safeguard the health of the public. Next, Deputy Chair, Professor Chan. I support the legislative amendments, but I have questions about the details. I support reforming the composition of the Medical Council by increasing lay participation. But my question is, how many more lay members will be included? Will it be added in one go or in phases? As for the complaint handling mechanism, will you require the lay members to have certain medical knowledge in determining the case? For example, will you include those with a Chinese medicine background or allied health professionals to join the Medical Council? I also support the enhancement of the procedures. For example, target time frames should be set for different parts of the mechanism. So what exactly are these targets? What if the target time frames are not met and no reasonable excuse can be provided? How will the personnel in question be taken to task so as to make sure that the objective of enhancing the procedures are met? About increasing lay participation, as I mentioned, these should be non-doctors who have certain medical knowledge. As I explained at the outset, the Medical Council's function is not limited to handling complaints and conducting disciplinary inquiries. In order to safeguard the quality of healthcare services in Hong Kong, we need to work on different areas such as training for medical students, assessment, registration, as well as drawing up codes and guides, allowing non-locally trained doctors to practice in Hong Kong. That means a review of their history, continuing medical education, etc. Now, complaint handling only forms part of the mechanism, and we're only going after a small portion of the profession who are not compliant. But we cannot put the cart before the horse and substantially increase the number of lay members just for the sake of it. I want to clarify that we want to increase lay participation, and we also need to ensure that there are sufficient professionals to determine cases. As for the target processing time frames, this is quasi-judicial procedure on the part of the Medical Council. As I explained, there are reasons for delays. For example, according to the case cited by the Ombudsman, there are judicial reasons, such as additional information at the coroner's court or due process. This particular case, if I may call it an outlier, is really outrageous. It took 10 years and it got stuck at the PIC stage. But we also need to have regard to the the average figures. Like I said, we have enhanced administrative support so that it won't take long for an expert witness to be engaged. We need to build a talent pool to make sure that it won't be too difficult to find an expert for a case, or it won't be turned down by a lot of experts, and then there is no time to compile the report, etc. We will set target timeframes and indicators as far as the administrative aspects are concerned. Thank you. Next, Mr. Chan Pui Leung. Thank you, Chair. I strongly support the administration's proposed legislative amendments in relation to the Medical Council of Hong Kong. I have two questions. On composition, I support increasing lay participation. I believe this will boost the credibility and public acceptance for Medical Council. Lay members account for 25% at the moment. By how much will the proportion of lay members be increased? The second point is about about insurance. I represent the insurance sector. Now, I'd say that the insurance sector is a major stakeholder, especially since we process a lot of medical claims. The Secretary just now mentioned inviting lay members who have some kind of medical background to join the Medical Council. Now, when it comes to claim assessment, we do have professionals with medical background in the insurance sector. Well, I hope that the government will consider inviting representatives from the insurance sector to join the Medical Council as well. The second point is about the PIC. In the past 5 years, 8,700 cases were received, but 7,000 cases were screened out by the PIC on the grounds of the complaints being frivolous or groundless, or no further information could be provided. Only 3% or 221 cases were substantiated by the PIC, that is for further inquiries. Will the government consider reforming the number of lay members in the future? But even if this is done, with the vast number of cases to be handled by the PIC, will the government consider setting up an independent complaints unit that is separate from the Medical Council, So to enhance public acceptance as far as the handling mechanism is concerned, because it's separate from the PIC, it's separate from the Medical Council. By setting up a complaints unit, this will help enhance credibility of the Medical Council.
Secretary. Thank you, Mr. Leung, for your questions. For lay participants or lay participation, the ratio for lay members in the council, we have, on top of lay members of the Medical Council, there are 84 independent assessors, 36 of them lay assessors. They are appointed by the different bodies. They have no relations with the Medical Council. So that in the preliminary investigation committees and inquiry panels, they play a key role, the independent assessors, especially the lay assessors. So the ratio of lay participation within the Medical Council does not necessarily mean that we do not have adequate lay participation in preliminary investigation committees and inquiry panels. If the ratio is too high, it will affect the operations, but then we do understand the public's concern. We will try to increase lay participation. But then we heard some lay members say they have a low participation because they do not know the professional matters of the medical profession, and it is hard for them to provide more information. I think it's with the input, it's not just about quantity, but also about quality. For lay members of the Medical Council, some of them can be appointed, so perhaps someone from the insurance sector can be one of them. When we talk about 5 years, there being 8,700 complaints being categorized as frivolous or groundless, I think we have to first look at why they are regarded as groundless and frivolous. I would say some complaints are valid, and why they are regarded as frivolous or groundless so early on, it is because the complainants are anonymous, or when we ask them to provide further information, they did not provide more information, which is why there are a significant number of cases that are not followed on beyond the preliminary investigation committee stage. And we have, on top of the chairman and deputy chairman of the preliminary investigation committee, there having to be an independent lay member that agree that the complaint should not go forward. All right, thank you. Mr. Chong Ho Fong is going to speak. I will draw the line after Mr. Chong has spoken. And for other members who are going to speak, I will be more strict with the time limit. I will extend the meeting by 15 minutes now as well. Mr. Chong, thank you. I note that in paragraph 12, there is some time indicators for the complaint handling mechanism. Will you electronize all parts of the process so that you can actually follow up on the indicators? You talked about there being sometimes passiveness. So will you perhaps, for example, if you have a 6-month time frame, at the 5-month mark, you will issue some sort of reminders. And if there is no reasonable explanation for not meeting the milestones, will there be a penalty? Because even with a mechanism, if there are no penalties, it will not be effective. After setting up the mechanism, will you share the time frames with complainants to enhance transparency? I know that within the Medical Council, there are 32 members, 24 of them medical practitioners, and 16 of them are nominated and elected in the profession. We have members from the Hong Kong Medical Association as well as the general practitioners. There are 7 of them. I understand with doctors, when they are studying medicine, they are already members of the medical association. So basically, all general practice practitioners are members of the medical association. It seems that Hong Kong Medical Association has is overpowering the whole election system. They're taking up 87.5% of the election pool. So is there something we can do to minimize their influence? Are there also other measures where we can adopt to have more non-locally trained doctors to come to Hong Kong, perhaps during summer holidays or other holidays, so that we can attract them early on before they graduate, so that they would want to come to Hong Kong after they graduate? Thank you. Secretary, we will try to make sure to use computer systems to make sure there are no blind spots in the process in the following up of the indicators. But we cannot be taking an across-the-board approach because, like I said, sometimes we have to have regard to judgments of the court because we have to ensure procedural justice. For example, we would still have to wait until the procedures in the criminal cases or the coroner's court are over before we proceed with the disciplinary inquiry. We also need to give some time for expert witnesses to provide advice, but of course we can have some sort of a time frame. But we can't really penalize the expert witnesses because they are obviously very busy and they went above and beyond to provide advice to the medical council. There are no great returns to be had, and they may even face certain pressure. But we will try to set some administrative targets. We will also enhance transparency so that complainants and family members of patients can know more about how the process works. As for the composition of the Medical Council, as I said earlier, we do want to have the members of the Medical Council to come from different backgrounds. We are already proposing legislative amendments in that area. As for whether we should have locally trained students coming to Hong Kong during holidays to have some sort of internship arrangements, we already have some learning arrangements promulgated by hospitals and universities. They are especially popular among Hong Kong students who are studying overseas, and they have really been attractive. Thank you. Mr. Adrian Ho, thank you, Chair, thank you, Secretary, and other members for raising their concerns. I believe with comprehensive reforms of Medical Council, it can restore confidence in the counsel of the public. We had different cases that had significant delay, giving the public a bad impression of the medical council. It also gives off the impression that doctors are protecting each other and they are just making decisions on doctors. I think with reforms, you need to make sure to restore confidence in the medical council as well as changing the existing impression. We have seen in different regulatory bodies related to the medical profession overseas would have a 50% lay participation. I think with other places having such a high lay participation of 50%, why can't we do that? Why not seek drastic change to change the public's impression? We really need to change the public's impression that we have doctors deciding the fate of doctors. Can we refer to the model of the Independent Police Complaints Council? It is an independent regulatory body that is very effective in looking into the complaints against the police. Can we have an independent body to conduct investigations so that there is a third party, perhaps not just in conducting investigations, but just in general to supervise the inquiries? Because the complaint cases sometimes involve the deaths of loved ones, and the family is going through the procedures not for any benefit, but for change. So we should really enhance transparency. I think you should only emphasize how complex the process is for citizens. Whether it is frivolous, it is still a complaint. Can we introduce a mediation arrangement so that even for the supposedly groundless or frivolous complaints, we can deal with such cases by mediation? It also frees up time for the medical council to handle the cases that are not regarded as frivolous or groundless. Citizens want enhancement in transparency. We really hope the Secretary can listen to us, to the public, so that we can have a comprehensive reform, so that we would not only have the doctors being players, but also the referees. Well, Mr. Adrian Ho has used up most of the time. The Secretary can just give a brief reply. Thank you. I will give an overall reply. With medical treatment, it is about failing standards, and we have peer review. It is necessary not just to see whether there is compliance with standards, but to make sure there is development or even enhancement of the medical profession. Let me give you an example. Say for organ transplant, say liver transplant, we would sometimes have blood vessels clogging. But if it is caused by error, when there is a clogged blood vessel, it does not necessarily mean the doctor failed. The smartest organ transplant doctor in the world would still have some difficulties in surgery causing clogged blood vessels. So the issue is whether in treatment, whether appropriate prevention, measures have been adopted. That's why we need expert witnesses to provide advice in inquiry panels. In fact, they are the key to the inquiries, and assessors would make their judgment based on advice of expert witnesses. And when you say one has failed such standards, even with increased lay participation, that will be determined by those in the profession. As for whether we can introduce mediation arrangements, the existing mechanism already disregards frivolous or groundless complaints. As I said earlier, in order to determine whether a doctor has failed standards, it's not just about punishment, but also about continuous improvement of the profession. We want to, through official inquiries, identify the problem rather than having doctors settle with patients or families through mediation. So we think we have to be really prudent with considering whether we can adopt mediation. Thank you.
Next, Ms. Grace Chan. Thank you, Chair. I have a question on the composition. The Secretary just now referred to the pathways. Now, my question is this. Will the Medical Council on a regular basis invite patient groups to apply to be a recognized patient group, or will they need to take the initiative to apply with the Medical Council to become a recognized patient group? Will you take this opportunity to amend the law so as to incorporate more patient groups as recognized groups? Secretary. Well, we have patient group representative in the Medical Council. There are 3, and they are returned by election among the patient groups. There is also, so it's an election process. You mentioned independent assessors. There are, at the moment, 36 of them. Nominations are received from different groups, groups of barristers, lawyers, accountants, and 6 of these assessors are nominated by patient groups. So there is participation by patient groups. Right, may I suggest that we extend the meeting until we complete the discussion of this item? No objection? Right. Next, Mr. Chan Hao-fong. The reform of the MCHK will help salvage public confidence in doctors and the Medical Council. So it's a positive thing. I think we must take this step. No matter how small this step is, we must make a move now. Other members put questions to the Secretary, and as I heard from the Secretary's response, there are reasons for the delays, including administrative and legal reasons. But from what I've heard, there are also delays caused by expert witnesses providing expert statements. How do we make sure that the procedures can be expedited? I know it's very complex. It may involve, for example, medical reports. And some experts may be reluctant in compiling expert statements. So what can be done to make sure that these doctors can work with the Medical Council in providing their opinion? Is it possible to compel certain expert witnesses to provide their statements in a specified time frame? Or if our experts in a certain specialty refuses to provide expert opinion, can we then invite an overseas expert to do so? Or can we leverage on AI to go through stacks of documents so that with AI we can conduct basic analysis and some straightforward processing and shorten the time frame for expert witnesses to provide advice? It's important that we compress the time frame, and it's also important for experts to give their opinion in the inquiry process. So I'd like the Secretary to elaborate on this. Secretary. Thank you, Mr. Chan, for making a very good point. You've actually hit the spot. Indeed, many experts are quite busy, and it's one thing that experts agree to be an expert witness, and another thing for the time an expert takes to compile a report. Sometimes they may withdraw midway. And some patients might have a very complex history. There may be stacks and even boxes of records involved. Expert witnesses take a long time to go through the patient records. And in fact, we have adopted some new ways, as you've suggested, such as engaging overseas experts. But I must say that it's an even more difficult process talking to overseas experts, and that there must be a reason why we look for an overseas expert. They also have a busy schedule. You mentioned compelling expert witnesses to provide opinion. Well, this is really tricky because no doctor has this responsibility of agreeing to be an expert witness. Now, AI, I don't think this is a good way of handling things to replace expert witnesses. Now, as I mentioned in my opening remarks, we are working towards building a talent pool. That is, we have a pool of experts coming from different disciplines, specialties, so that there is a sufficient mass. This can provide great support to the hearing process for the engagement of experts as well as for the whole profession. I also hope that my fellow doctors will also take this responsibility and be expert witnesses so as to ensure fairness of proceedings, because we can't rely on those outside profession to determine whether the professional standards are met. This is a very important task. I hope I've answered your question. Next, Mr. Nick Chan. I need to disclose interest, Chair. Thank you. I chaired the Standing Committee on Compliance of the Law Society of Hong Kong. I took part in the disciplinary hearings, and I also took part in the PIC IP hearings of the Medical Council. So through this experience, I would say that I didn't observe the situation of a member, the profession regulating a member of their own, but because of the case that surfaced last year, I believe in terms of due process and fairness, we need to improve things, and I have the following suggestions. I agree with Ms. Chan and other members that a separate unit should be set up to fulfill the function. Well, there is already this panel of assessors in the Medical Council, but still it's still part of the Medical Council. We should set up a separate unit which is independent of the Medical Council. It should carry this independent title as well. Second point, in the Medical Council, we have some really hardworking members. They have been members of the Council for, say, 2 decades. I think we need to be innovative Perhaps we should observe the 6-year rule as in the case of other advisory bodies and committees of the government. Now, at the lapse of a 6-year period, they should withdraw from the membership. Perhaps they could come back after the transition period. As for hearings, now every week we can handle 70, 80 cases. We can conduct a 5-hour hearing. But every time I see lawyers carrying boxes of documents, can we at least scan the documents and go digital? And also honorarium. It's $405 a year. That's for doctors' registration. Can we increase the registration fee so that we can pay more honoraria for the participating members? As for the penalty guidelines or the sentencing guidelines, we have accumulated a lot of cases over the years. So you should analyze the cases from your database and promulgate the guidelines. Point number 5, waiting time. Well, this is not only the problem relating to the medical council, but the law courts in Hong Kong as well. Say, can you tell us exactly when the hearing would be held? Say 9 months on, 6 months on, and that if the professionals' diaries are full, you should engage someone else. Finally, resources. May I ask for more staff from the Department of Justice to be seconded to the Medical Council? Secretary, thank you, Mr. Chan, for the many questions put. You were an independent assessor of the Medical Council. You have the actual experience, so you have pointed out some areas for improvement. I find them very helpful. It's not just about chanting slogans. There are many objective factors affecting the outcome of how a complaint is handled. You have mentioned independent assessors, PICs, and inquiry panels. Now, actually, they run independently. It's just a matter of perception that that people feel that it's the Medical Council making all the decisions. So I very much agree with you that we should do something about the title of these units. For example, chair of the inquiry panel should be one elected by independent assessors, because these independent assessors are not part of the Medical Council. Just like yourself, you represent the legal profession. As for going digital, I agree that there is a need to do so. It's difficult, however, to turn patients' records into digital ones. Honorarium. This point has been raised before. Medical Council members are working pro bono, but they spend a lot of time on the work of the council as well. In fact, we do have similar committees and boards under the Department of Health and the Hospital Authority, and these members also work pro bono. They provide free service to maintain the quality of healthcare services in Hong Kong. So for Medical Council members, I don't think the dollar sign is really the top of their mind. As for penalty guidelines, I think the panels go by precedent cases. It's actually the practice adopted by the judicial proceedings as well, because if you meted out penalties that are particularly harsh, you may be facing judicial challenge. Now, as for listing of cases, I think you are familiar with it as well. Say for the inquiry panel, it comprises 5 members. The proceedings also involve the complainant, the doctor being complained against, their respective legal representatives, legal advisors. So it's a big team, and each case may differ. But as you said, in terms of the Department of Justice's legal officers, we would like to strengthen support for them as well, and it's included as part of the enhanced administrative support.
Next, Mr. Shukafai. Thank you. I understand that for the 32 members of the Medical Council, they are not receiving any remuneration for dealing with the cases. I thank them for their work so far. If you want to reform the council, increasing lay participation from 25%, what is the ratio you have in mind in future? And will there be an increased number of members as well? Secretary, I understand many members are paying close attention to this. We do have something in mind, but we cannot talk about it today. But the general direction is to increase lay participation. But even for medical members, we will have those coming from other backgrounds, so that will enhance diversity. For doctor members, we will think about for the joining of the medical council. Right now, for medical members, not one of them is appointed by the government at the moment. So perhaps in future, if the government can appoint some talents to become members, this is a good reform direction. Thank you. Right now, we observed the Medical Council has received an increasing number of complaints. It's threefold the number before, and 8,000 complaints were handled between 2020 to 2024. In general, it would take 27 months to process the case, and 40 of the cases were completed within 2 years. 98% of the cases would be completed within 4 years. I think that the general public does not think that these are appropriate time frames. We do thank the 32 members of the Medical Council for their efforts so far. So I think even with the increase in lay participation, if you do not increase the number of members and they have their own commitments, they can't do this work every day. How can we shorten the waiting time for complaints to be handled? So I would suggest to the administration to increase the number of members to, say, 64, and then we can discuss the ratio of medical and lay members. But it's just simple math. If we have more members, before someone would have to wait 2 years for their case to be handled, now they would only have to wait for a year. And there may be a heavier workload for the secretariat, but then if we deploy more manpower, they will, or if we have an increasing number of members, it would be easier for them as well. I am saying that before the members are already working hard, I think the solution is to increase the number of members in general. Secretary, Mr. Xu, at the beginning, with the Medical Council, when they deal with complaints or hold inquiries. It's not just the 32 members who will take part in the procedure. We have 84 independent assessors that will take part as well. And they come not from the medical council. They have a background in different fields. They come from legal associations. They come from the ICPA as well as other organizations. So we have within the 84 assessors, 36 of them being lay assessors. When you talk about to deal with complaints and hold inquiries, we have to increase the membership of the medical council. This is not necessary. We can have a larger panel of assessors, and we have not used up all of that quota. We have 6 independent assessors being nominated, and at most we can actually have 10. That is something we can do. Well, can you double the number that we have for assessors? As I said earlier, we have 84, and that's 6 assessors from each body, and we have 10 at most. So we can have a maximum of 140 assessors. I think this is what we can do to shorten waiting time. I think the secretary meant they can increase the number of assessors rather than the number of members because it may not necessarily help with the situation. All right, the last one to speak would be me. I want to follow up on the tracking of cases. Right now, at monthly meetings, we would have the preliminary investigation committee's report on the progress, but they only give simple information and members are not aware of the details as a result. But they can't know about the details because if the members take part in the inquiry in due course, it would cause unfairness. And it is difficult for members, therefore, to know that some cases are basically lost and are not being dealt with. I think we need to have members of the preliminary investigation committees and inquiry panels not to overlap with members of the medical council. And then we would not have the problem of fairness being tainted by having council members hear about the details of the cases in the preliminary investigation committee stage. I actually already wrote a letter to the Bureau. I want to ask if the Bureau will consider my suggestion in this legislative amendment exercise. Secretary, thank you. Chair, you are a medical practitioner and you had been a member of the Medical Council for quite some time. You are quite familiar with the operations of the Medical Council. You said some cases were not followed up on, and that has caused delay. I understand that the Ombudsman, as well as the Council's internal review, highlighted this issue. To maintain independence at monthly meetings, the Medical Council members cannot discuss in detail what preliminary investigation committees and inquiry panels are doing. They only can know at what stage the case is and how long it has been. To ensure procedural justice, they cannot be involved in the discussion of the details. We really need to resolve this issue. And if we split these powers from the existing powers of the Medical Council, we are concerned, as we said earlier, that the Council may not be aware what stages the cases are at. As for your concern raised on illegal medical practice, we this is not our focus in this legislative amendment exercise. We are focusing on the regulation of doctors. We'll see if there are any other ways to plug the loophole. Thank you, Chair. Thank you, Secretary. I want to ask if members support the legislative proposals made by the administration. I see no objections. Thank you. The next agenda item is any other business. I have no other business. Meeting adjourned. Thank you.